Hello, everyone, and welcome to our webinar today. I am going to slowly transition into the start just as folks are joining us. I know virtual transitions can be tough, as I think some of us in the production team was just experiencing as we even entered our call today. So welcome to today's webinar, From Framework to Impact, Equity-Oriented Care in Practice. As we get started today, you should see a poll pop up on your screen. We kindly ask that you please just take a moment to answer this so we have a sense of who's joining and where you're joining from. Next slide. Today's session is available in both English and French with simultaneous interpretation provided by Boost Events. To access the session in French today, please look for the interpretation menu on your toolbar and as shown in the slide. You might need to click more to find it, but once you find that button, just select French. And also please select either English or French slides, and you should see that at the top of your Zoom screen, and that can make sure you are seeing the written language of French or English. Next slide. We're also pleased to offer today's session with American Sign Language and French Sign Language provided by ASign. If you use this service, please select either American or French Sign Language from the interpretation button, again, as shown on the screen. I want to thank all of our interpreters today, including our sign language interpreters, Dean, Christy, Joelle, and Marie-Jacques, as well as our French interpreters, Luna and Mariana, sorry. And a big thank you to our production team, Miranda, Gina, Jill, James, and Emily. Now, I'd like to introduce myself. My name is Brady. I use the pronouns he and they, and I'm joining you virtually today from my home office on the traditional and unceded territory of the Algonquin and Anishinaabe people, which is colonially known as Ottawa. The land I'm on sits alongside the Kitchissippi waterways. Part of my ongoing commitment to truth and reconciliation is learning about the histories of the communities who have cared for this land and continue to care for it today. I acknowledge settler colonialism as both a history and an ongoing process that needs our collective attention. And I invite everyone to please take a moment today to reflect on the land you're on and the Indigenous peoples whose territory you're joining from. I'm also a senior program lead on the Patient Safety, Equity, and Engagement team at Healthcare Excellence Canada. Next slide. The topics we're discussing today might be challenging as we're exploring the topic of health equity. So we wanted to make sure that counseling support is available to anyone who may need to access it, whether that's during or after today's session. So the numbers on it has been shared in the chat and is on the screen, and it's available until 4 p.m. Eastern today by phone or text. Please take care of yourself in ways that work for you. Next slide. Bruce couldn't join us today live, unfortunately, but he kindly offered to open us in a good way through a pre-recording. So I'm going to ask my colleagues to get that up on the screen so we can hear from Bruce.
Okay, well, good morning, everyone. Welcome to this webinar, Health Equity webinar, the second webinar. Excuse me, Danse Kiawao, Mio Kasipiao, and bonjour. What I said was hello, everyone, and good morning. I am presently at home on the traditional lands of the Malahat and the Cowichan tribes. Originally, I was raised on Treaty 6 territory in Alberta. I've been in BC since 1972, but The Health Equity Framework is very important work, and we what you're doing is for the future here and the present of working with different organizations and communities. The communities are very important to this, and to have them involved. Also, if you're at the hospital or the doctor, you can maybe talk to a physician about cultural safety and how they see this. Recently, I was at my doctor for my annual and physical, and I asked you, how about do you guys do any cultural safety or do you? She said, I'm not involved. She said, some of the staff have been, but the this whole um, procedure or this evaluation, whatever we're going to do, and we are all doing good work for the indigenous people and for the non-indigenous people. We have quite a multicultural mix of people, but I'm very honored to be a part of HEC and you know when our dialogues around cultural safety and indigenous health. It's you learn so much from everyone. Everyone has a voice, and that's the important piece of it. So uh, I guess the message I want to make is that please have a good dialogue. Don't be afraid to ask questions or pose statements. It's really important that we drill down and have a good webinar on from different aspects or opinions of different people. So uh, enjoy the webinar. Thank you.
Thank you, Bruce. We're sad you couldn't be here today with us, but I'm sure folks can get a sense of the energy he brings even through a recording like that. Just a reminder, if the slides were brought down, you might need to reselect either English or French on the top. As well, the poll we opened with had closed prematurely, so if you didn't get a chance to answer it, it should have just popped right up on your screen. Next slide. Thank you. I want to thank each member of the Virtual Learning Exchange Advisory Group. So each person you see on the screen here played a very important role in shaping the sessions that we've hosted this month. So great gratitude to all of them. Thank you. Next slide. So we wanted to give everyone a quick recap of what we discussed on March 4th. If you joined us then, I'd actually invite you now to please share in the chat what was a highlight, what did you learn, or what might be something you're feeling curious about, whether that was after the webinar or the weeks in between this webinar and that. If you missed it, don't fret. The recording has been shared and it will be shared in the chat today as well. And I'm also going to do a bit of a walkthrough to help set the stage today. Next slide. On March 4th, and so in our last webinar, we introduced the Healthcare Excellence Canada Health Equity Framework as a tool to help individuals, teams, and organizations advance health equity. The framework is intended to meet you where you're at, whether you're just starting or have years of experience doing this kind of work. In the session, we talked about how systems create unequal care experiences and how changing those systems require working at 4 levels at once, at a structural level, organizational, at a relational level, and the individual, the work we need to do ourselves. We talked about how targeting change should happen across all of those levels I just described, and how that's important to the framework and action. In healthcare, that could mean changing policies, practices, nurturing relationships, and reflecting on assumptions that we hold. The framework also shows us where we have influence to act, and it gives us 8 actions that we can take. The actions are shown on the screen today. I won't be able to get into them now, but if you watch the recording from our last session, you can learn a bit more. Next slide. Many things stood out from the conversation, but we wanted to highlight a few. Lou's story was shared at the start of the webinar, and it was a reminder that care experiences can look very different depending on who you are and where you live. And that's not by chance, but often by the design of how systems are set up. We talked about what safe and high quality care means, noting that it means more than just clinical excellence, but it's about asking what matters to you, and then how will we know if we've made a difference? In the discussion with Jennifer and Christina, you see them on the screen here, it was emphasized that sustaining change requires shifting our belief systems and mindsets. So not always just changing the policy, which is important, but changing how we think and show up in this work. And I think we heard quite clearly in the conversation and what was coming up in the chat that we need to bring people along on this journey by really leaning into what is our shared purpose, what brought us to this work, the field of health and social care, and doing that in a way that we know what's at stake if we don't, and really putting our energy towards the desire to care for people and communities. Next slide. So today, our journey together, we're moving from framework to impact. You're going to hear from people and teams who have put health equity into practice, from what worked well, where were there tensions, and what helped to create meaningful change. We're going to start with a patient partner perspective, and then you're going to hear from 2 teams, all folks who have participated in collaboration with HEC over the years, whether that's in co-development or our Enabling Aging in Place program and our Proving Equity in Palliative Care program. So we have an incredible lineup today. Next slide. Now, before I hand over to our speakers, we wanted to hear from all of you. Just a brief activity. Using the chat, what stands out to you as an important ingredient for advancing health equity in practice? Again, please share your ideas in the chat, just to get a sense to see what we're all thinking as we head into today's presentations. I'll take a peek at the chat to see what's coming in. Yeah, humility. I feel like humility is such a big one. Diverse voices, yeah. Ceremony and ritual, yeah. Thank you, Stephanie. Common understanding. Understanding the past in order to inform the future, yeah. Spirituality, yeah. Putting ego aside. Thoughtfulness, okay. These are all great ingredients. They're certainly the ingredients I would like to see in the recipe that is achieving safe, high quality, and equitable care. Please keep sharing in the chat your ingredient list, so to speak. And I'm now going to hand it over to Prachi, who's going to get us started with our first conversation of the day. Prachi, over to you, and I think we're going to bring the slides down.
Thank you for joining us. My name is Prachi, and I use the pronouns she, her. I am a first generation settler to the ancestral, traditional, and unceded territory of the Coast Salish people, a place I consider home, now referred to as Vancouver. So I engage in the health system as a patient partner and also do so professionally. So actively involved in researching pediatric pain from a lived experience perspective as a patient, in critical care research from a lived experience perspective of a young caregiver, and also professionally in my work. I'm also involved with supporting pan-Canadian initiatives in equity as well as population health. And I find that I want to start by sort of contextualizing my positionality and share with you that these are perspectives and experiences that inform all the work that I do. I find it gives me a unique position, gives me a unique perspective as somebody who engages in this work from a lived experience perspective, but also engages people with lived experience in my own professional work. So I want to begin by discussing my involvement first in the co-development of the framework and some of the work that you're seeing presented in this webinar series. So I've been involved in the co-development of the framework since September 2024. So this has involved being a part of the dialogue that formed what you see as the Health Equity Framework that has been produced and disseminated by Healthcare Excellence Canada, as well as implementation guides and as well as this webinar series. And I continue to be involved in ongoing development of additional materials. So I want to talk a little bit about what my experience has been like in co-developing. So for me, it has been a truly transformative experience. I want to know it was the first time since becoming involved in the healthcare system in the spring of 2020, around the beginning of the pandemic, that I experienced this tight feedback loop, and I was just so eager and excited to engage. And it was fascinating to see in real time how my feedback shaped how it is that we articulated the framework that you see today and that has been shared with you. One of the key components that stood out, and I saw some of this pop up in the conversation in the chat as well, but the prompt earlier was having shared goals and a shared moral language. That's at the foundation for work in health equity. I want to now shift my discussion to how it has practically shaped my thinking on equity and what it means to take a systems level approach to equity. I want to encourage us to think about how we need to reimagine patient safety. And it needs to be not only from the perspective of the system and those who work within it, but also from the perspective of people and the communities that it purports to serve. So that warrants a broader and a more proactive approach that evaluates the ability to succeed in varying conditions, not focusing only on the negative outcomes that happen within the system. So what that means is that we need to acknowledge every day that the work that we do in the complex system of healthcare is variable and flexible, and it must be in order to serve communities and meet them where they are. But also it needs to be equipped to address conditions that are often unexpected, such as the system pressures that we experience today and are often not under the control of frontline workers in order to meaningfully produce equitable health outcomes. Patients and communities need to be involved in defining what health equity and safety means to them. And a key component that I also saw come up in the chat earlier was trauma-informed approaches in practice. So what does that look like? It's something that came up in our discussions in co-developing the framework as well. So how is it that we meet people and communities where they are? How is it that we are going to break down the hierarchy and think about patient safety in ways that people that we serve see it? Part of this includes, and I say that from my lived experience as a patient and as someone who navigates the health system, receiving services and care, does include physical and psychological safety. So going beyond adverse events, going beyond adverse outcomes, asking the question, what matters to you? And part of that is the safety component. So trauma-informed practices need to be operationalized to create that sense of safety, that felt sense beyond the operationalized definitions that we use in our work and our research and our initiatives. I want to also share some of the other pieces that came up in our discussion. So the trauma-informed component is key. I think we need to appreciate how is it that trauma shows up in our lives as well as the lives of the people we care about. It's important to acknowledge how is it that trauma shows up in our lives so that we can come from a place and we can function from a place of reflexivity in the work that we do in the system in order to serve people where they are, meet them where they are. That's all for me. I look forward to our panel discussion in a little bit. I want to pass on the mic to folks from Golden Healthcare. We have Roslyn, Compton, and Kimberly Quam who will be sharing about their work.
Thanks very much, Prachi. And if we can go to... Thanks for the slides. So it's a pleasure to be here today and to have this opportunity to share our experiences working in Golden Healthcare. And if we can, I'm Roslyn Compton. I use the pronouns them, they. And today I'm joining you from Treaty 6 from Saskatoon in Saskatchewan. I'm originally from Australia, so the treaty system here is very different to the system that I'm used to in Australia, but the important piece is that connection to land and understanding who we are in relationship with each other. I'm the Executive Director of BetterLTC, and I'm also an Associate Professor at the College of Nursing, University of Saskatchewan. I'll let Kimberly introduce herself now before we move to the next slides.
Thank you, Roslyn. Kimberly Quam joining you as well from Treaty 6 territory and the land of the Métis. I am the Community Engagement and Program Development Specialist with Golden Healthcare, and I'm very excited to be here with you today.
Thanks very much, Kimberly. Next slide, please. So we were a part of the Enabling Aging in Place collaborative program with Health Excellence Calendar. We had the goal was to enhance the ability of older adults with health and social needs to age where they call home in the community and formal support. Our team was based at Golden Healthcare at Diamond House in Warman, and we looked at the alternate level of care program. This is where older adults who no longer need acute care transitioned into an alternate level of care program, and we provided support and practice from a relational care lens and looked at how we can maximize health and wellness outcomes for older adults and help them transition to their next home, which may not be their permanent home, but their next home, and to support and with their resources. Next slide, please. Before we begin, I wanted to start to introduce you to Anne and to share part of Anne's story. So Anne's story starts with, to begin with, I was living with my daughter and kids. We were sharing rent, $500 each for a 3-bedroom apartment. The older of my granddaughter was supposed to be my caregiver, but all of the things were not talked about. I'm a diabetic, and I also had water retention real bad in my feet and legs with lots of edema. My knees were really big and the fluid started oozing through the skin and made sores. I couldn't even wear shoes. This caused needing the wheelchair. Then my granddaughter was smoking up and she was different. She would cry when I asked her to do something and wouldn't do it. I don't like to tell this, but it happened. I would sleep in the lazy boy. I was trying to get up and I fell out. I had to start wearing Depends. Again, I fell out of the chair and I soiled myself. More than the Depends could hold. I called and called, but no one came. Here, on transition, when she came to Diamond House and wrote, "His is good, but I'm not used to having everything done for me. Look, like cooking and laundry. I don't have much to do. I try to keep tidy. I do crafts to keep my mind sharp. When I first came here, I thought I have lived with white people before, and they were good and welcoming. We didn't feel any different. This was when I lived with my sister after being raped at 15. Here at Diamond House, I tried to break the ice at the table many times and just couldn't. They didn't say anything, the other residents at the table. The staff spoke their own language. A few of the other residents would say, speak English. It seems that the older people are the more I see white supremacy. And shed, I'm comfortable here. I don't feel the intense emotional loneliness I felt in the hospital. I could live anywhere with anyone, but family is family. There was a time when Anne left us, and she said, I left Diamond House feeling a little uncertain about how things would go. No one had found a personal care home that I could afford, and there was some pressure to move. So it was decided by my family that I would live at my grandson's house. He rents out rooms, and a room had become available. His girlfriend would be my caregiver. Not all of my family was in complete agreement, but it was the best plan we could make. Anne returned to Diamond House after, in some ways, care was renegotiated and she returned to us. It has become her forever home. As Anne has settled in and felt the safety of her new home, her brilliant sense of humor has begun to shine brighter with each passing day. Her laughter often fills the halls, reminding everyone around her of the joy that comes from truly feeling at ease. Anne has opened up to share reflections from her life, stories of food insecurity, hardship, loss, fear, judgment, balanced with moments of courage, resilience, and joy. Anne's journey is a reminder that wellness isn't just about the body. It's about belonging, purpose, and knowing you are safe and supported in the place you call home. At Diamond House, Anne has found her rhythm again, a life filled with care, connection, and joy. And for all of us, watching her thrive has been a beautiful reminder of why we do what we do, helping every person live well, age well, and feel truly at home. Anne's story really calls our team to think about how we come together and looking around in our meetings and thinking about in the Zoom room whose voice is missing and what are the challenges along the way that help us to shift and grow. By paying attention to the many parts of Anne's story, we have been reminded of what people bring into the care environment, their past experiences, their past stories, their past understandings of what is care and how we care with people relationally. There are many challenging instances as we work through our project. What we found is that we needed to lean in more and more rather than back away. We often found our need to talk, to reflect, to share stories, to laugh and to cry. We had to surround ourselves with value-adding experiences and people. It's really important to bring together people that hear and see you, but also hear and see the people we are caring with in a relational way. As a team, we became humble. We recognized that learning involves taking risk and standing up for what the team and the people we're caring with believed in. This risk sometimes felt too large, sometimes very overwhelming, sometimes suffocating. At other times, the risk for moments of joy, of being able to stand back and say that we did this. We stood true, we stood fast, and we stood together. We also found there isn't one answer, and there is no answer that always holds true. You need to seek multiple truths. And by seeking multiple truths, we're reminded that there is many ways to see the world and there's many lenses to view the world. It provides people the opportunity to speak freely, to share their experiences, and to engage with each other in meaningful ways rather than just superficial. It's those deep, meaningful conversations that our team grew the most, but it is also the opportunities where we made the most changes within our care environment and also within ourselves. We have to be flexible and to explore possibilities. And this is something that when we entered our HEC project, sometimes we were a little tentative. However, the more that we grew as a team and the more secure and safe we felt with each other, the more flexible we became. It's important to begin with, I don't know, and recognize we all have assets to share, and we need to give space to be present with and to each other. By starting with I don't know invites other people to share their experiences, to open the conversation, to look outside of ourselves, to look bigger than ourselves and our organization that we are sharing within. It also invites us to invite other people to the table. And oftentimes during our project, we were constantly inviting new people into our world. Maybe they stayed and maybe they were transitional. Maybe they returned. There was never an expectation that if you left, you could not return. People came and joined us in moments of need or in moments of our need in response to questions, seeking answers, or trying to find a possible solution for the challenges we were facing. This fluidity in the team is really crucial, and it gives us a chance to honor our strengths, our connections, and our partnerships. It provides us this opportunity to move forward beyond partnership to meaningful collaboration. It also provided us the opportunity to spread and scale, to reach and connect with other people pursuing very similar activities to ourselves, who were trying to shift care practices from being task-based to being relational. We really needed to, at the end, and continue to do so, is that we need to look beyond ourselves for possibilities. We are not necessarily the answer. We have possible answers. We're not necessarily the one with the correct solutions. We have possible solutions. We have different ways to offer up and explore what it means to care relationally with older adults, but also how to care relationally within our teams, with our team members, and with ourselves. And I think that for me, this is probably the biggest reminder when we're caring with people to see. And what Anne talks about is to see her, not to see what we presume, our assumptions, but to stop and to really be present and to see the person standing in front of us and also to see the person reflected back to us. So thank you, and I'd like to pass it on to Kimberly now. And I didn't progress the slides, and I'm very sorry. There is a next slide, but we'll progress past my slide and we'll go to Kimberly's slide. Thanks very much.
Thank you, Roslyn. I appreciate you. And I appreciate the fact that you shared Anne's story so beautifully, so raw and honest, and so powerfully. I can honestly say that during our Enabling in Aging in Place project, Anne was by far one of the people that really changed who I became as a person and who I am and how I perceive care, and especially how I look at advancing health equity. Next slide, please. So during our project, we really found that health equity felt like a large and sometimes complex concept. But when we broke it down, it really came back to how we thought about the people we serve and the systems that we had created around them. At its core, we determined that advancing health equity was about ensuring that every person can receive safe, respectful, high-quality care, regardless of their background, identity, or circumstances. We created a shift within the organization and within our partnerships and within our working groups. We changed how we approached working with our older adults. And we really did a deep dive into looking at what does relational care mean to us and to the people that we serve. Next slide, please. There are many strategies and frameworks that support this work, but what you're going to hear from us is a couple of our key takeaways. Roslyn hit the nail on the head when she said, listen to the people, listen and understand real experiences. When we look at inviting feedback from the people that we serve, it helps us to improve the care. In our busy healthcare environment, we would spend a lot of time listening to what people had to say, truly listening, truly listening. When we shifted to a true culture of listening and not just hearing, we started asking questions and really nurtured that culture of curiosity that Roslyn spoke to. We quickly discovered that our residents and the families in their circle of care often had insights into healthcare systems that we couldn't see from within our organization, from within our own experience, and within our roles within the project. Our people experienced the systems differently, and their perspective revealed barriers related to culture, language, geography, provision of care, access to services, and really would bring a lot of insight to us on their prior healthcare experiences. So what we did is we created opportunities to hear deeply and listen to those perspectives by asking simple questions. So talking about curiosity, we would ask hard questions, even though we knew that sometimes we wouldn't always be prepared for the answer that we would receive. In the case of our resident Anne, she had not been asked where she wanted to go. She hadn't been asked whether she felt safe. She hadn't always been asked to contribute to the decisions that were made for her. They weren't necessarily being made with her. And when she made the move prior to coming to live with us, there was concerns about her basic needs being not met. When we began to listen and really, really hear and ask hard questions, we gained a deeper understanding of how care is experienced on the ground. So listening helped us to build the trust. And what we found is that when people felt heard and respected, they were more likely to engage with care. Up until this point, Anne hadn't been asked what she needed. She wasn't asked where she wanted to land, where she wanted to live, what needs were not being met. And when we started to do that, it allowed us to plan with her rather than for her. We engaged with Anne in a way that kept us truly involved and brought her to the table and allowed her to have a voice. Let me be honest though, truly listening isn't always comfortable. There was many, many moments of discomfort. And as a team, we discovered firsthand that being uncomfortable was okay, and that some of our greatest learnings came from the discomfort we felt when we truly listened. Next slide, please. The second action we took was to commit to culturally safe care. Cultural safety means recognizing every person brings their own cultural identity, values, and experiences into the healthcare setting. Within our program, we would often see our residents coming from either acute care setting or the community to our home. And it was meant to be a transitional space. We were a way to help, and we would work with our partners to provide opportunities to care plan and to help our residents develop a sense of where they wanted to go, but also really engage in reflection. And so what we did is we spent time not only reflecting on our own perspective and assumptions, but we really tried to understand how our own perspectives and assumptions often influenced how we delivered care. Simply put, meaningful actions such as respecting cultural practices, using specific language, being curious rather than making assumptions, and ensuring that care environments reflect the communities that we serve, helped us to shift in how we really listened and how we paired listening with cultural safety. Throughout Anne's journey, she often seemed hesitant to discuss her care. And what we come to find is because culturally that was not the norm. For her, she was used to having contact with family and talking bigger picture. And so what we did is we noticed that she rarely asked questions and would often quickly agree with whatever was being suggested. So instead of moving quickly through the conversation, our wellness team paused and asked whether anything would help her to feel more comfortable and allowed her to discuss openly the decisions about her own care. By us simply asking the people that we serve what they needed, it allowed us to make a small adjustment and really allowed people to be heard, but also shifted the way that we provided culturally competent care. Sometimes it simply means being curious, asking thoughtful questions, and respecting how residents approach health and decision-making. And for us, that wasn't always comfortable because we are very system-based. But for me, that example highlights what culturally safety care can look like when we put it into practice. Next slide, please. Our third takeaway concerns the systems and the policies that shape healthcare. And even well-intentioned policies can sometimes create barriers for certain populations. That's why we discovered that applying an equity lens to decision-making was so important. It shifted the way that we ask questions, the way that we develop processes and practices. And before implementing new programs or policies, we asked questions. We asked things like, who benefits from the decision? Who might face challenges accessing the service? And what might we be unintentionally leaving out? These types of questions helped us to identify gaps and enabled us to design more inclusive and accessible solutions with the heart of our residents right in the middle. Next slide, please. One of the most important ideas to remember is this: health equity isn't a separate initiative. It's a lens how we design and deliver care. Sometimes in healthcare, we think about equity as a project of policy, something that sits alongside the rest of our daily work. But the reality is that equity should influence every decision that we make within the healthcare system. It shapes how we design programs, how we develop policies, how we interact with our people, and how we support our workforce. When we approach our work through an equity lens, we notice barriers that might otherwise have gone unseen. It helped our organization to identify whether certain policies might disproportionately impact groups already who face barriers. We ask things, are we assuming that everybody has the same access to resources? We would ask, how will we know if this decision will improve equity and care? How does it help us to focus on relational care? When equity became part of our decision-making process, it moved from being an abstract idea to something that actively shaped how we supported care and how we cared with people, not for people. Advancing health equity doesn't happen through a single policy or initiative. It happens through consistent, everyday actions across our system. When we listened to our residents' voices, when we nurtured a culture of curiosity, when we asked questions, even as hard as they might have been, we sometimes sat in the discomfort. And what we did is we shifted that perception that it wasn't safe and it wasn't okay to be uncomfortable. And we knew that we could sit there, we just maybe shouldn't stay there long. And we would go to having constructive conversations and really problem solving as a team. Next slide, please. We thank you for your time, for your willingness to listen to our presentation, your willingness to listen and to grow. And we invite you to reach out to us directly if you wish. This is my contact information. Next slide, please. And this is Roslyn's contact information. I appreciate your willingness to attend today. And with that, I would like to welcome our friends from the George Spady Society.
Hi, thank you so much. That was really beautiful. And the work does sort of mirror what we do in ways too. So hi, everyone. My name is Lindy Dowhaniuk. I'm the Director of Health Services for the George Spady Society. And with me, and she'll speak a little bit later, is Michelle Velaquette. She's the Program Manager and Social Worker for George's House Palliative Care. And we are living and working in Treaty 6 territory, also known as Edmonton, Alberta. So health equity for us sounded very abstract. It lived in policies and in frameworks, and we now see equity as a verb. So it has to be lived out in the work, and that becomes very, very real when somebody is dying and has nowhere safe to go. We were part of the Improving Equity and Access to Palliative Care Collaborative, supported by the Canadian Partnership Against Cancer. And that slide, the next slide, sorry. It included 23 communities across Canada working to improve access to palliative care for people who are structurally vulnerable. Being part of this initiative has been so valuable to us, and it will continue to guide our work for years to come. It really renewed I was kind of, especially after COVID, at a bad place in my career, and this really renewed, it like filled my bucket, and I'm now absolutely in love with palliative care and equity. So next slide. So George's House opened about 7 years ago to fill a gap for people who were structurally vulnerable and needed end-of-life care, and that needs just continues to grow. So in Edmonton last year, we had nearly 4,700 people were counted as houseless, and it was a 47% increase from the year before. So structural vulnerability means life expectancy is about 34 to 47 years compared to 80 plus for the general population. So 60% of those experiencing houselessness are Indigenous. And although Indigenous people only make about 6.8% of Alberta's population, so those are realities deeply connected to colonization and systematic inequality. Next slide. So we're not talking about people diagnosed with one illness who have support systems around them. We're talking about compounded, complex trauma, often from childhood, layered with multiple serious illnesses, concurrent disorders, and survival strategies built from incredibly hard lives. And then a healthcare system hands them a diagnosis, and that, of course, will assume that they have a home, a phone, a toilet to throw up in, a fridge for medications, someone to bring them water. The social determinants of health aren't background context for this population. They're the difference between accessing care and dying without it. So managing end of life from an emergency room or a shelter cot or a tent is hard for the person who is dying, for their loved ones in their community, and for the staff trying to care for them from places that were not meant to do this kind of care. That's the gap that George's House exists to fill. Next slide. So George's House is a 5-bed palliative care home. It's situated in a really nice little neighborhood. It's a house with 2 common spaces, a kitchen, a fish tank, a pretty yard. Residents have their own rooms. They're quite large. And basically, it's a home. So it's a home where people die supported and cared for. Often they are cared for in ways that they actually needed their entire lives, but never got, which makes me sad, but I'm also glad that they are getting it at the end of life. No one has to die alone at George's House, so most will be reconnected with loved ones, and in rare cases that they are not, they make new loved ones. It's really quite beautiful. So we have a 24/7 team of an LPN and a healthcare aide around the clock, and then we have Michelle as our social worker. So we work with assisted living palliative home care team who will come in and do some of the more complicated things, and then the Indigenous wellness clinic. We also have access to our organizational cultural helper and psychologist, and residents can use substances safely. We don't make people choose between substance use and palliative care. It's an unrealistic barrier, and we've deliberately removed that. And as someone who also runs a supervised consumption service and a detox, it surprised me how naturally substance use just falls away when people feel safe and valued. Next slide. So equity means changing the system. So we can politicalize it, we can moralize it, but people are dying on the street, and substance use and houselessness is often treated as a reason to deny care. On top of that, emergency medical services are strained, and so moralizing substance use or criminalizing houselessness strains the health system even more. So for us, equity means redesigning the services around people's actual lives. So at George's House, that meant 3 shifts. So housing, a stable home is a foundation, not a reward for sobriety. Accepting people as they are, removing substance use as a barrier to care, asking somebody while they're dying to also stop using something that has helped them survive is very unrealistic and a little bit cruel too. And of course, cultural and community grounded care. So ceremony, traditional practice, as a core part of care and not a checkbox. So these 3 shifts are what equity looks like in practice for us. So it's not a policy statement. It's just a regular day at George's house. Next slide. So to connect this back to the equity framework, what it did was give us language for things we were already learning through our practice, addressing systematic barriers, centering lived experience, cultural safe care, anti-oppressive approaches. It helped us see this not as like a small program in Edmonton in this little house, but of a larger movement. Yeah, so I'll hand it over to Michelle, who oversees our operations and client care directly, and she can speak on what the day-to-day really looks like.
Yeah, thank you, Lindy. It is important work, and we've come so far. So within these 7 years. So next slide, I'll talk on culture as medicine. So with our cohort partners, Cookham's Helper, she took on an Indigenous cultural support role at George's house, not supplementary but core with the care team. Grounded in culture as medicine, it meant someone who could provide Indigenous-led ceremonial care. We see this often as residents arrive and refuses cultural support. We respect that. We follow their lead. But with the cultural helper, she keeps showing up, not pushing, just being present, slowly building that trust. By the time they die, they connected to culture, community, and family. They live in a good way and they die a good death. No one else on our team could have made this happen. Indigenous people have been doing palliative care for thousands of years. Pipe ceremonies, smudging, cedar bath, washing, traditional song at bedtime, drumming. There are not extras. For many residents, they are the most can receive and have received with the Cookham's Helper. Next slide, please. So with community care, we had, and with the Health Equity Grant, we were able to get SOLAS and the loss tenders. We hired a community engagement worker with that grant who's focused on connecting with residents through families and broader community. The road led us to SOLAS, which is a grief and loss organization. And through their partnership, volunteer community members called Lost Tenders joined our residents and staff. They were artists, caregivers, mothers, elders, people with lived experience, and neighbors as well. They showed up not as professionals, but as people. They built a casket with one of our residents, with his guidance, which was really special. We held grief circles. We threw a block party, which was something new, but was fun. They showed up and just being themselves gave the residents a little more like they're not staff, but they're just people coming in, regular people where they can connect naturally. And it was really important connections in that time. It transformed George's house into a community and reminded us that palliative care has existed for thousands of years. And outside of the health system, we learned to honor that. Next slide. There's a messy reality working within the system. So this work deserves more than just success stories. Constructual obligations and community care are intentions, and the intentions are pushed us to ask hard questions about which rules protect residents. Which rules protect residents, which are just habit. Our staff carry deep emotional weight. They build real relationships, they build trust, and then those residents die. There are not enough beds at George's house. There's only 5, so people stay on waiting lists. They are sometimes pass away in hospitals, not great situations, and most of the people that we serve are kind of not trust of institutionals, so that is a disservice to them and unfortunate, but it's our reality right now. There are people in the waiting list, like I say, that we cannot help. and that it's hard to sit with, but equity work means staying inside those tensions and moving forward anyway. Next slide. The biggest lesson here after all this is equity is relational. Policies matter, fundings matter, but what changes outcome is trust. Trust is huge. When people feel safe, they accept care. The nurse is the doctor, a hand to hold. When people feel respected, they reconnect. Residents who had spoken to their children, haven't spoken to children in years, get to pick up the phone. When people feel like they belong, like someone will notice when they are gone, they find peace and leave legacies. So a lot of times we see our patients who build that trust, who did not, trust the system, but they trust us. And then they do reconnect with family and that. And it's such a big part of their passing, because then they pass with all that connection and support and care. Next slide. So this is the end of the presentation, but I just wanted to have you watch a little bit of a clip about George's house and what it looks like to feel like a home. And yeah, so I hope you enjoy it. And thank you so much for being part of our presentation today. You can play the clip, please. Yeah. Thank you.
We're taking some breakfast orders. What would everybody like?
I don't know. It's just something that people are so disconnected, or they don't get treated well, or they come here and they finally feel what love is.
This place has been a life changer for me. It really is going to be the last place closest to a home.
Was this place what you expected it to be?
Better.
Better?
Yeah.
Yeah. That's good.
It's, I wish I had more of these places.
Bread's ready.
Oh. Very good.
I want to try first dibs.
I'll slap. Thank you. better place than what Bonnie thought it'd be. It's not awesome.
It's an honor to know you, Bonnie.
It's an honor to be here. I know.
Hi, everyone. I'm feeling lots of big emotions right now, and I'm sure others are as well. So I just want to remind folks that counseling support is available, and the number has been shared in the chat. I want to give good thanks to all of the folks who just spoke and sharing the work they're doing. Human-centered care is what comes to mind for me in all that you talked about. I also want to thank folks for engaging in the chat as well. I saw lots of good conversations happening. Before we move into the panel, I just want to take a moment to pause and really acknowledge what was just shared, the stories that were just shared. I think they remind us of what's truly at stake when people seek care and their needs are not being met, and why the need to feel safe, supported, and seen is so important to what we do. And when experiences happen for people navigating different care systems, especially painful ones, they follow them. They shape how and whether they show up. And I think in these moments, I'll go back to why our human to human connections become so important. So thank you. Thank you to all of the speakers and I'm sure the good of people you work with for your vulnerability of sharing with us today. And I think it's going to help shape the conversation moving forward. I want to pull together a few just simple threads as well. Prachi, you shared how being part of building the framework gave you a lot of knowledge and confidence to speak up when systems were not working for everyone. And you drew a clear line between equity, patient safety, and engagement, and why these things should not be siloed, but they're actually one and the same. Roslyn, Kimberly, you made it clear that health equity it's not a side project. It's the lens we use to design and work through all care. I think through Anne's story, you showed us how whiteness operates in systems and why we need to keep looking inward. I think a few things you said that will stay with me is seeking multiple truths, listening with curiosity, and the power of choice, and caring with people, not for them. Lindy and Michelle, you brought us face to face today with what happens when systems were never designed with certain people in mind. And you reminded us that equity means naming and changing those systems and not squeezing people into services that don't work or fit for them. One thing that is especially going to stick with me is two things around the social determinants of health. They're not abstract, they don't need to be, and they're the difference between getting care and not surviving. And that there are traditional practices that have been out there and have existed for longer than we can tell, that have always worked to honor end-of-life care. So I think we're all sitting here now and probably have lots of different thoughts and ideas moving through our minds. And I know there's some questions top of mind for me and for folks who are in the chat and responded through registration about how do we make this work part of everyday practice? What do we do when teams are feeling stretched or when systems might feel like they're pushing back? And when the people who need care the most are the ones that the care wasn't designed for. So these are big important questions, and we want to try to talk a bit about that today. To wrap us up, I should say. I'm going to invite the panelists to come back up to the screen. We can take down the slides so that we can see everyone. Thank you. Thanks. And we're going to move into our discussion panel portion for the next 23-ish minutes. Hi, it's nice to see you all. Thank you again for speaking today. We prepared some questions just based on some of the burning questions folks were asking through registration, and want to explore that with all of you. So one of the big questions that we wanted to surface today as a real tension that emerged centered around what helps people recognize equity not as separate from quality and safety work, but as something that is core to everything we do in good care. How do we make this connection in everyday work? What have you learned in your own practice that made this achievable? Especially if you're in high pressure environments with multiple priorities, what are some of the things that worked for you? Prachi, I'm going to suggest we start with you to share some thoughts and then encourage others on this wonderful panel to also chime in.
Thank you, Brady. So to begin with, one of the foundational ideas that has helped me conceptualize how I approach this and sort of solidify how I approach equity work is this realization and acknowledgement that what we do and how we think and what we think is informed by our imagination, which is formed by our experiences. So in order to do equity work, I think we need to challenge our own imagination. Pressure is a constant. The system change tends to be slow, but people make it work. So the good news that we have as people who work within the system is that we can build our sense of agency. How is it that we are going to act within our sphere of influence and make change and promote equity? This is something very tangible that I've seen in my own practice. The need to think about equity every day, system change being slow, but what can I do today? What can I do now? How is it that I honor the person in front of me? How is it that I honor the work that I do? What is my commitment? So little drops in the bucket every day over time. You know, you're going to have a bucket to carry eventually. And that's a thought that gives me hope. So really approaching it every day, thinking about it every day, being mindful of how it is that we do what we do every day. Pressures change, pressures come and go. Pressures are like waves, but we are the constant. We are in the system. What is it that we're going to do today? So those are some of my thoughts. Thank you, Brady.
Thanks, Prachi. Roslyn, I'm looking at you. I feel there's something you're going to share here. So please come in.
I was just thinking about what Prachi was saying and talking about, and I think the important part is taking those moments to breathe. And I see in the chat there's equity into practice can feel difficult when teams are already stretched with many priorities. And I do worry that sometimes we get immobilized by the priorities because we haven't taken time to stop and breathe, to really think about what is the priority for who we are, where we are at the moment, and who the people are that are present or not present. So I think and also then when we do identify those tensions, is taking that time to have a conversation, to reflect for ourselves, but then also to encourage the team to reflect, whether it's an activity, whether it's a huddle, whether it's putting up sticky notes, whether it's, sending a message to somebody else. But how do we acknowledge other people, and how do we acknowledge their work and their contributions, and how do we keep that momentum when we may be feeling stretched? And how do we hold space for each of us is really important.
I can kind of jump in too, and oh no, go ahead, Kimberly. Sorry. Okay, go ahead.
Thanks, Lindy. I appreciate that. Well, you know what? Just to kind of add to what Roslyn and Prachi both have said is I think for me, I started exploring equity and we were talking about safety, we really spent a lot of time asking the question of what does safety actually mean to the person we're caring with, right? And so for me, this was so uncomfortable because I had beliefs of what safety meant, and what safety should look like, especially caring with older adults. And so I think, with Roslyn's guidance and our team approach, sitting in that uncomfortableness when we're challenged, our beliefs are challenged, and we are challenged to look at something in a new way, it really gave me the opportunity to explore how I was feeling in my beliefs. But breathing, when Roslyn says just take a breath, that was so important, right? Because what I realized is that there's a lot of emotion that comes with us when we're caring with people. And I came from a system where we cared for people. Decisions were made for people, not with people. And so being involved with this project shifted my mindset on my approach. And what I discovered is that sometimes living safely truly meant supporting our people to live with risk. And that's okay if that's their choice. It wasn't always comfortable. So I think for me, equity, I think of it as separate from safety, because for me, it's what allows me to really think about care in a different way, and really allows me the opportunity to ask the questions that will help me support providing care that is more complete for the person that we're working with and for them as a person and as an individual. And so we shifted from trying to fit the people into the system to asking those really hard questions. And it took a lot of adjustment. Not all of our partners and not all of us at the table at any given time were really comfortable with asking those challenging questions, but it helped us to support that change. So.
Power of choice.
I could kind of add on to that because when you say safety, what comes to my mind is the way that staff will often feel unsafe when they're dealing with an escalation. Most people will come into palliative care not trusting the system, not sure if they can trust us. We've got to really build that relation with them, and they're hypervigilant. Sometimes they're, even as far as volatile, or they'll swear, they'll throw something or whatever. And then, so the danger comes in that the staff have a feeling of danger, which they might not actually be in danger, but that danger feels real for them. And so we want to address that. But then when you're doing this kind of work that is always in the gray, never in black and white, it's hard. And so if you were to discharge somebody, that person becomes incredibly unsafe. So what we do is, of course, we do nonviolent crisis intervention and stuff, but we go even further in having classes on, FASD, brain injury. We do a lot of training on understanding the person in front of you and understanding your own bias and your own triggers, and then really and reminding them of it, doing it often. And then also debriefing. So making sure that we're understanding what worked, what didn't work. And also debriefing after a relationship ends. So after somebody has passed away, Michelle will always have debriefing and celebrations of life where they talk about oh, when Ricky came in, do you remember he was like this? And then when he warmed up and started to trust us, it changed so much. And just making sure that's always part of the language and always part of the discussion.
Thanks, Lindy. Michelle, I'm curious if there's anything you might want to add.
I think Lindy summed it up pretty well. Yeah, it's just we understand the population that we serve too, right? So with the training, as Lindy said, comes into fruition sometimes, but yeah, you got to look at the gray. You got to kind of put your, I don't know, I say put your feet in someone else's shoes and see, just kind of get out of your own comfort space and realize, where they're coming from, right? And we don't always see that. It's one in so often, but trust is huge, and that's where the big barrier is at first. You see that. They won't trust you. It's baby steps with people. And when you get there, it's so beautiful. So, yeah. Well, thank you, Lindy. You probably summed it up better, but I'm just saying, yeah, it's just a really beautiful way of seeing people just let go and just trusting people for once, eh? And the system, they trust. We're part of a system. We don't want to be part of it, but we're there, but they just trust it. And it's great. Yeah.
I want to underline the importance of that trust. During my own time working more at the point of care in patient experience and relations, it's something we feel, right? When there is trust with the human in front of us, the patient, the client, it changes the trajectory of how we are able to be together. And even if you're in the system's not working how you want it to, when you have the trust, it really makes that world of difference to be together and to find the solutions that are going to work and make sure that they are going to receive the most dignified care. So I really appreciate that point. We had another question that I wanna pose because I think it's an important one. And this came a lot again from what we heard from folks in the registration as attention. We know that advancing equity, it means changing how sometimes things have always been done, and change can be challenging. So I'm interested. Maybe we'll start with Roslyn, if you want to start. What has helped you move equity from something people say is important to genuine and sustained commitment with clear accountabilities for the work, especially if there's various readiness across the team you might be working in?
I think it's really important that each person finds how it fits with them. Not each person can't wear equity the same way, and sometimes we make them wear equity, and I think that is a real issue. Some people are not ready, and to force them into it actually is more harmful to them, but also to the people they're caring with and also their team members. So I think, when we sit with tensions of equity, I think we have to go slow. We have to meet people where they're at, as we do with all care. And I think when we meet with people where they're at, we actually have to listen to them, because we can't just say, well, you'll get used to it, or it will become more comfortable, or you can do it, because some of us just can't. And sometimes those hard conversations about maybe this isn't the work for you, but also what assets do you have? What strengths do you have? What can you bring to this team that doesn't make you accept equity, doesn't make you wear the equitable lens that I want you to wear, but helps you to start to see that you do fit in, you are valued, and that you have a place, because also the people that we're caring with don't necessarily come from an equitable system. They don't know what equity is. So how can we expect them to actually engage in equitable care when people may not have ever had an opportunity, or have not had that chance to see a difference or to be different? Because if you work in a system that is compressing, that has expectations, that has rules and regulations, it's really hard to step out and say, hey, I can see this differently. I can do this differently. And then when I do step out, how am I appreciated? How am I valued? How am I seen? And how do I translate that? Because my past life may not have given me compliments, may not have ever seen me, may not have let me talk about or even encouraged me to talk about that maybe I don't believe in equity. Maybe there's something else that's going on and I haven't had a chance to look at that. So I think it's just so important. It's at the moment, it's the flavor. There'll be something else that comes after equity. And as we keep making all these shifts, people don't necessarily keep up, are not sure of the most recent terminology, isn't sure of the recent definition, isn't sure how to use the word in what context, and they're also then not sure how it's going to be received. So yeah, there's lots to think about.
Yeah, you know what? And it's really interesting because when I hear you speak, Roslyn, I couldn't agree more, right? I, I had to go back and Google it. I'm like, I think I'm getting lost in the terminology. What is equity? What is it supposed to mean? And for me, it was all about having the conversation and getting down to basics for myself first, and truly understanding the lens in which I was looking at my experiences through, and what I was bringing to the table within our project. Right, from a relational care standpoint, when I started to really, really understand what it meant to look at the person and care with the person, I realized that my experiences really, really shifted. My beliefs shifted, I guess it is, and that my expectations shifted. And so I had to be ready. I had to be prepared that not everybody would be shifting at the rate that I was, and not everybody is comfortable, right? And so when we talk about that discomfort and sitting in the discomfort, we would joke. It would be like, we would say things like, hey, this feels like we're passing a kidney stone, right? Like this is painful, but it was okay. We didn't have to panic and try to get out of that discomfort really quickly. Because I think what it allowed us to do is to really look at how can we better support people? At the end of the day, our people are the foundation of the work that we do, right? And specifically within our project, what we are seeing is that a lot of the individuals that we were caring with, they came and there was barriers in place the minute that they walked through the doors, right? And so if you were somebody who came and were admitted, came to us in the project and in the system from acute care, and you had a circle of care and you had the financial means to contribute to where you would land and where your final destination would be, things look different for you. Then the length of stay with us was shorter, right? You had a different type of voice, and equity often meant something different, right? When we think back to Anne's story and we talked about food insecurity, I think one of the hardest things that I had to discuss with the staff was their perception of she would come to a meal and she would take any leftovers back with her, right? And I would be like, do you want an extra bowl? Let me get you a container. And staff would approach her and be like, well, you can't take that with you. No, she can. No, she can. And if you would like something extra, then let me get it for you, right? And so then it was looking at how can we support her in a way that was safe for her, right? And now it's not questioned, but I think part of it is really examining our approach, but also what are we bringing to the table?
Thank you, Kimberly. I'm looking at the time and mindful that there's two brief, we want to do one more brief sharing and then close with Ed. But before doing that, Lindy, Prachi, Michelle, is there any final thoughts you might want to share, whether on the question or just what's sitting in mind right now?
Just really quickly, to put that into like practice for what we did, we just reviewed all of our policies and we thought, which of these policies exist to keep people safe or because of funding and contractual obligations, and what's archaic? And we got rid of what was archaic. And then we also embedded client and family advisory groups, focus groups, surveys, work-life pulse surveys for staff. So we have clients, families, and staff contributing to everything that we do. And then through that, we do action plans. So we don't just get that information, we put it into action. So we make attempts at making sure that that is throughout our entire organization.
Yeah, thank you, Lindy, for highlighting the tangibles, the operationals of it, the process. One of the pieces that comes to my mind, sort of circling back to the idea of challenging the assumptions that underlie our work. So when we say safety, by whose account, by whose definition are we assuming that safety piece comes from? In some of my teaching and facilitation with interprofessional students, this is something we really try to spend a lot of time on, which is, so you have a person in front of you, and how safe do you think they feel? There's really no way to know unless you ask. So if I can close off with one comment, it would be to ask, not assume. Don't assume trust. Assume you're starting with nothing, because it needs to be built over time, right? So those are some of those pieces. I only know what I know, what's sort of confined to how it is that I think and think about the world and look at the world. But I don't know how Brady thinks. I don't know how Roslyn thinks. And it's not my place either. So really asking those questions, clarifying, exploring with curiosity, openly. You never know what's going to come your way. People will surprise you. Yeah.
Okay. Michelle, any just final notes
Yeah,
before
just
we move?
maybe just a big thank you to everybody. And I think we're all kind of holding this like big ball, I call it big ball of yarn that we all kind of mold together and our unique abilities, and we collaborate together to make it work. And I think it's very special, and it takes a village. Honest, it does. So networking, everything is very important. So this presentation was really great to see how we're all kind of pulling that yarn together, molding it together. Yeah, thank you.
I envision a beautiful quilt being built
Yeah.
now. Thanks for that. If we could kindly get the slides back up, I'm going to just wrap us up. Apologies, I know we're tight for time. So thanks again to our wonderful speakers. Seriously, I struggle to say in just a short amount of words how appreciative I am. A reminder that counseling support is available. The number has been shared in the chat. Next slide, please. We wanted to share a bit about just what to expect from HEC in the coming few months. We also have a final poll coming up. We ask that folks please just fill that out as I'm talking about this and as we move into Bruce's closing. So the poll should be up. So we have been busy at HEC thinking about where do we go from here. So coming in the next few months, we're preparing to release and make available to all of you different supportive structures and resources to help advance health equity work. This is going to include implementation supports, varying from how to kind of plan to more bite-sized pieces around how do you reflect and build accountability agreements. We are also starting to do a lot of deep thinking into evaluation as well. What does equity-centered and decolonial approaches look like for this type of work? So please stay in touch with us. It's a very quick summary. Next slide, please. Here's the email that you can use to reach out if you have any questions to the HEC team or want to know more about some of those quick things I just spoke to on what's coming next. And I'm going to say thanks to you all, and we're going to bring up a video just to close us off in a good way today. Thanks again.
Hello, everyone again. I hope you've had a great discussion and dialogue around health equity and, like I said in the first place, this is a very important work for all of us, and we want to, compile and look at this and for an evaluation, and just keep doing the work that you're doing. Everyone has a voice, and so I wish you well going home to your loved ones. Maybe you're working from home, but if you're traveling, we live in a beautiful place here on Earth, on Turtle Island, and in Canada. So just take what you got from this webinar, and we'll keep working together and make it the best we can. So thank you very much for being here, and take care.
And that concludes our webinar today. Thank you, everyone. Thank you to our speakers. Thank you to our production team, and thank you to all of the interpreters.